Hello, my name is Dr. Sarah Walker, and I'm honored to serve as the 2025 President of the El Paso County Medical Society. On behalf of our organization, I want to welcome you and thank you for tuning in to the El Paso Physician. For the past 28 years, the El Paso Physician has been dedicated to serving our community, and we are grateful for the continued opportunity to bring this program to you on PBS El Paso. This would not be possible without the generous support of our community sponsors who help us produce valuable content every month. If you or someone you know is interested in supporting this program, more information is available at 915-533-0940 or at epmedsoc@aol.com. Thank you again, and we hope you enjoy this program presented by the El Paso County Medical Society and hosted by Catherine Berg.
When you're being treated for a medical condition, your health care information is vitally important. And these days, it's getting easier for doctors to have it all at their fingertips when they need it. We all know the feeling of filling out medical forms, and you have noticed over the last several years that this practice has become a bit easier, especially if you're going to the same healthcare provider. There has been collaboration and technology in our community that is advancing so much that your providers have now the information together all in one central place. This is especially important when there's an emergency and they need your information. Today, we're going to talk about how healthcare information is being shared in our community and how it can help you and our community and also your kids and grandkids. This evening's program is underwritten by the Paso del Norte Health Information Exchange, and we also want to thank the El Paso County Medical Society for bringing this program to you. I'm Catherine Berg, and you're watching the El Paso Physician.
Thanks again for joining us. This evening, we're going to be talking about the understanding of the importance of community health data, as well as improving patient care through data sharing. And we have with us Dr. Joel Hendryx, who is the Chief Medical Officer of University Medical Center, and also a board member of FIX, and I'll explain what that is in just a moment. And then we have Dr. Hector Ocaranza, who is the health authority. And I always think of what? But no, you're the health authority. Also the medical director of the Department of Public Health and also a board member of FIX. And then we have Emily Hartmann, who has been with us several times, even when we were putting all of this together years ago. I feel like it's been about a decade, and that's why it's so interesting to have this show today of what things are different. But you're the executive director of FIX, and that's spelled PHIX, Physicians Health Information Exchange. And that's what we're going to be talking about this evening. And what I'd like to do, Dr. Hendryx, if we can sort of stop for a minute. So in your role of Chief Medical Officer, and then also as a board member of FIX, explain your role here today. Because I know you've got 1,000 different roles out there, but for today and for tonight's discussion, explain those two roles.
Certainly, as a representative of El Paso County Medical Society, my role is to be able to present to the board and to work with Emily and other physicians. We have a physician advisory group, and it's there to be able to help advise, to listen to feedback, and give them feedback. Try to help them with their initiatives, saying, this makes sense from a medical point of view, or it makes sense from a patient perspective, and try to encourage other members in our community, physicians, to be able to participate. We've been very fortunate that the different healthcare systems have all joined together and now have information given to FIX. And that kind of coalesced during the pandemic, which was very vital. Very vital is how we managed to get through that. And El Paso was a leader in that. And so that is my role, is to be able to help communicate back to the County Medical Society, to our physicians in El Paso, and also to help give initiatives and work with Emily on those initiatives as we move forward.
And I feel like it's just been speedy over the last several years, because when we talked about this originally, it was just about getting one system on board and then two systems on board. And I want to say our first program with you and I, Emily, and I don't remember who else was on there. I believe you were as well. It was about 7-8 years ago, and we were looking at just getting one hospital system on, and now all of them are on. So I would love for you, Emily, if you could, again, as the executive director, and you're the founding executive director, if I understand that right, and if not, I saw you go like this, so you're not. In my experience, it's always been you, but talk about the startup of all of this.
Sure. So in the beginning, it's talking about the potential value and working with folks like Dr. Hendryx and Dr. Ocaranza and other peers in the physician committee to talk about what could we do if we had all of a patient's medical records in one place. Theoretically, when they go into the emergency department, that'll benefit their care. And now it is almost a decade later. I think I've been at Fix for about 8 years now, so it's been a long time. Now we have those real stories for providers talking about their patients. When it was actually at University Medical Center, one of the emergency department physicians from Texas Tech was telling me that their workflow is that when the patient comes into the emergency department, they'll pull the patient's driver's license and look up what's happened with that patient, what if they're having a cardiac issue, what medications are they on, what procedures have they had, so that they can best direct that individual's care. And so we're really fortunate now with really broad participation. We have all of the hospitals in El Paso. We have Texas Tech. We have Emergence Health Network. We work with the VA. We work with the Department of Defense and William Beaumont. So having all of those partners, data flowing through the system, it really allows it to be beneficial to the physicians in the ways we were dreaming of, 8-10 years ago.
So here's an odd question, and it's not something we talked about earlier, but say you have an issue, you're in El Paso and you're in the system here in El Paso, but now you're in Montana on vacation. You talked about being able to have a driver's license. Is that a system that is nationwide, becoming nationwide? You said Dr. Hendryx at El Paso was really great about getting this all together. Where are we in America with that dispersity, I guess?
Sure. So we are a regional organization. We're a local nonprofit to El Paso, and we work into southern New Mexico and West Texas as well. But we connect with peers at a national level, and we connect with other types of national networks so that information can flow from an organization like ours to others across the country.
Very nice. I love hearing that. Dr. Ocaranza, so through the years, goodness gracious, we've done all kinds of stuff.
Definitely.
So in your role here this evening, again, you're board member of Fix, and I know we're going to talk in a little bit too, what broad benefits that Fix is to the community. But in your role here, what is it that you're doing with Fix, with the health department as the health authority, et cetera?
Well, in this day in time, data is so important to be able to objectively respond to anything. And the COVID pandemic was the best example. Fix was instrumental in being able to people get appointments to get the vaccine, to get the results on the COVID testing, because the health department was the only one that was doing COVID testing at that time, and people needed to have the results. Fix made it possible. So bringing all the data together and basically all the providers sending the data to Fix and Fix being able to distribute to whoever needs that data was pivotal to have a better response. And it continues to evolve because now we're able to see what's been going on in the community. That is called the syndromic surveillance. When a lot of people get sick from the stomach, whether it is a virus, whether it is food poisoning, we will be able to see the effects of this, because people are going to be buying medications for diarrhea, buying medications for cold, especially now that is the cold season. And if people, after buying the cold medications, end up in the emergency room, now we're going to be seeing a lot of those patients coming to UMC, coming to any of the hospitals, and together that information gives us an idea of what is happening, and we can start having education, vaccination, or other countermeasures to keep the community safe and healthy.
So here's a question. I think about it then. Remember when we were kids, or our children, we have to provide the vaccination, the sheets before they go to school, before they go to college. Is Fix a place that adults have their information, their vaccination information? I'm just thinking this right now as a mom. For example, somebody asked me, when was the last COVID vaccine you had? And I had to go in my desk, find my little card to see which one it was. And I feel like a knucklehead. I'm thinking, well, I'm sure that's listed somewhere. Is it? I don't know. I'm just kind of throwing that out there. Is Fix part of that, to where, yes, it's your medical information, but it also shows if you did get the flu shot, if you've had your shingles vaccine? I'm just thinking about the different things that are optional right now.
So we do receive vaccination history, whether it's pediatric or adult, if it's part of the medical record that's shared with us by our partners, we do receive it. We do not, however, have a patient-facing ability at the moment. Right now, we're limited to providers being able to access data for their patients through the system.
Okay, that makes sense. And so on that, this is me just coming up with questions as you're talking about it. I know you provided questions, but for example, if I am with a specific hospital system, and there's several in town, but when I go to register for my upcoming appointment, check in, and then a lot of my information is already in there, which is so fabulous, because the last time we did the show 7 years ago, that was kind of the things like, every time you go to the doctor, you sign the same things, you fill it all out. Now it's all there. And for the most part, you just change something here or there. When that is the case, when you said it's not patients entering the information, that information that you're giving to the provider, the patient giving to the provider, then that information is shared. Is that correct? Is that how I'm hearing that?
So,
yes, Dr. Hendryx?
Well, I think that, so if you go to a hospital, depending on which hospital you go to, you've been to another hospital, you've had another lab test, that institution has to access FIX.
Okay.
It's not a pop-up. It just says, "Oh, you've got this," and that's something they're working on. Mm-hmm. So it's not pushed to the hospital. They have to actually access it. And certainly with time and as people get more used to it, and the benefit, the value of that information, whether it's your private doctor or an institution, they have to access it. And that's something that Emily and her team are working on, looking at a new platform, making it easier to find that patient and to be able to access it in a meaningful manner, so that you don't spend a lot of extra time.
Exactly.
And therefore, that information is so vital, whether it's an X-ray test or whether it's a medication, all the things you were in the hospital 2 weeks ago. Well, when I was in private practice, it took me a month sometimes to get information from the hospitals, right? Because it had to go through manually. And now it's just a matter of looking on FIX and being able to say, yeah, that's you. I can verify that. And yes, well, you did have that. Okay, I don't have to repeat that test.
Right.
I need to do it in 2 months. I need to be able to follow you up. Or the medications that you receive from the hospital. I can access that and be able to help tailor your care based upon that current information.
God, the convenience and accuracy of that, I think was fantastic. We talked a little bit right before we went on air about each hospital system having a mandate by CMS, and Emily's like, do you know what CMS is? I'm like, no, I don't. But it's the Centers for Medicare and Medicaid, but there's a mandate to have a plan, to come up with a plan. And who is best to describe that of the three of you? I'm throwing that out there. I think Dr. Hendryx brought it up earlier.
Well, certainly, so CMS, which is they are the ones who help pay for Medicare and Medicaid, right? It's Medicaid, it's a state program, but it is funded through the federal government. And with that, they come up with guidelines and they come up with suggestions. And part of that is that we have to, at this point, start documenting social determinants of health and be able to start analyzing the needs of the patients within our system. Then with that, in the coming years, we have to have an action plan. So each hospital system will have to do that, right? So, which is important, which is good for the patients. So if I live in a certain zip code, then certainly there are certain social determinants of health, whether it's food insecurities, whether it's transportation, whatever that is, we have to understand that and be able to put the resources that we need, that our community needs, to be able to address those. So that on an individual effort to that patient going to a clinic, whether it's our clinic, whether it's a private doctor,
right,
that they will be able to understand, you know what, this person really needs some extra care and extra questions on what are the barriers to them getting care. Why do more women get better care than men? Because they don't go to the doctor, right?
Exactly. Emily had brought some things here, and I think this is a perfect transition to that. So access, let's talk, and it's going to be Form B. So we're going to put up a form on the air for you, and this is the relationship between food access and health. And this is specifically about diabetes that we're talking about here. And Emily, if you can kind of explain to the audience here what we are looking at. The example is type 2 diabetes, prevalence and food access. And just having this kind of information, how is this beneficial to the community?
Yeah, sure. So what you're seeing there is
The purple is showing you access to food. So the darker purple areas there are areas of our region that are greater than 1 mile away from a grocery store. And that is the definition that's commonly used for a food desert. And so what we've overlaid that information with here is the prevalence of type 2 diabetes, which these guys are both far better qualified than me to describe type 2 diabetes, but it's related in part to lifestyle, so your diet and exercise. So not living in an area where there is easy access to healthy food could have an impact on the prevalence of type 2 diabetes, which is what this is, a first step that we've taken to try to understand that relationship in our community as part of planning with all of our partners about when you're thinking about patients, not just within the healthcare setting, but as a whole person and their whole environment, understanding both the prevalence of type 2 diabetes, but also other drivers that might be contributing to that, like food access is important.
And so how is this information, I see this as part of the bigger picture, how is this information gathered, put together into this kind of a format?
Yeah, so we're, from the healthcare side, what we're doing is we're taking the records that we're receiving from all of our partners, and we are de-identifying them, meaning that no individual's information is available. So it's a private way of aggregating data at a community level. So we have statisticians and informaticists who are doing that work in our offices and partnering with epidemiologists to help do this type of analysis. And then looking at the food access data that you're seeing is from the U.S. Census.
Okay.
Or I'm sorry, no, it's not. It's from a different resource that my team's using to understand grocery stores, where they are, and then applying the U.S. Census definition of what a food desert is to that.
And we were completely separate in my other life. So I'm with the El Paso Community Foundation, and we operate downtown, and there really isn't a grocery store downtown. And so this issue comes up quite a bit when we're talking about downtown insecurities. What I'd like to do, Dr. Ocaranza, because it's kind of your turn to talk, with this same information. So we're looking at some of the initiatives for vaccinations around town, and this is the form number C. If we can talk about this too and what folks are seeing.
Yes, there's a lot of things that we can see on this graphic, which initially, if you see, you have peaks, you have colors, you have different things, but what it helps us to determine is, okay, how much influenza are we seeing in the emergency rooms, in the doctor's office? So those are the big peaks that we see in the lower right corner of the graph. And with that, we need to think, well, what can we do to avoid having these people go to the emergency room, getting hospitalized, and making other people sick as well? And now we put it in perspective as far as the map of El Paso. Where are all these people that are sick coming from here in El Paso? And if we see the zip codes, we know that vaccination is extremely important. Education as far as prevention is extremely important. So our teams of educators can go to specific zip codes to talk to them about washing your hands, covering your cough, don't leave your mocos everywhere.
And I'm going to walk away with that today. Don't leave your mocos.
There you go.
Right.
We're parents. You know how we're always after our kids.
I do.
And also bringing the vaccination to all these places that perhaps they don't have a right to go and get their vaccine. That's the non-medical drivers of health. That's part of the social determinants of health. Other aspects that can influence either positively or negatively into the health of somebody. So looking at a more holistic view of the health of the community, the health of the family, the health of each individual, there's many factors that can affect, and we can modify those factors. And we as public health look at those and see how we can modify those factors or eliminate barriers so that people can access the care that they need. And this way we will see in the trends of the disease, in this case specifically the influenza, how can we modify to make it better? How can we avoid these people end up sicker than what we normally would see somebody with influenza? So that is extremely important when you put together data and analyze it in a way that it comes to the health of somebody, whether it's the individual, the family, the community. that's what Fix is doing, putting everything together so each one of us in the panel, in the medical community can see it and address those issues to make that person better.
I kind of like that because it's helping to predict the future so you can help prevent some of the things that may be coming about. I heard a little start from you, Dr. Hendryx.
Well, I just to add on to what he was saying. So certainly we have perceptions, right? My learning is that you have to validate.
Right.
We don't have that data, but the data that they're bringing to us now helps validate what we suspect. When you have that validated data,
right,
then you're able to really marshal your resources, go get grants, go get, talk to your government, talk to city leaders and say, this is the data, this is what it's showing. This is our community. Let's work together with this data that we validated to be able to help take care of a healthy community.
And what I love hearing about, again, part of us going on air, I feel like El Paso, you said El Paso's been really great about this, and the city actually gave a grant to help with this information as well. So it really is, we're all in it together, all healthcare systems, which, again, kudos to El Paso, because I know many cities do not operate that way. So
very much so.
Oh, fantastic for El Paso on that. Emily, I'd like to bring this up because it made me raise an eyebrow when you talked about this. So also in this study, you were talking about climate and how climate and air pollution actually affects the likelihood of having a heart attack. And as you were saying too, we have suspicions, and when we have studies and we're looking at information, it helps validate some of the things that we're thinking about. So with this study, this is fascinating to me, environmental factors and health. If you'd like to kind of go through this one too.
Yeah, of course.
Help you out there.
So this is work that we did both with El Paso County and with the city of El Paso to look at exposure to different types of pollutants. So we pulled publicly available data on different types of air pollutants in El Paso and overlaid that with respiratory encounters that individuals have in the community, as well as heart attacks, myocardial infarctions, and found that there is a statistically significant relationship with both. And I personally did not know that air pollutants could cause myocardial infarctions because I'm not wearing a white coat at this table.
I would not have known that at all unless you said that earlier.
Yes. So it's been, to Dr. Hendryx's point, an opportunity to validate what the medical community knows. And then I think once we have that information, there's an opportunity for public health messaging so that others can be aware of risk and understand, the public health things that they could do to help mitigate that risk as well.
If I'm a pulmonologist and I know that my patient's being exposed to high levels of nitrous oxide, then, what am I going to do? I need to talk to them. I need to help instruct them on either not going out or wearing a mask or doing something different so that they don't have an exacerbation or that it end up with a chronic disease. So,
right.
This is what I think that data and validation does.
And then we're looking too at different areas of town that are higher and lower, et cetera, et cetera.
Yes, that's not shown on this diagram, but we can also do this geographically so that you can understand your risk by where you live as well.
So going on that question too, because I feel like we're so associated with New Mexico, at least, going back and forth, but I know that the hospital systems are different. And I think I asked this earlier, but I may not have asked it in the proper way. People who are traveling back and forth with Las Cruces, because I feel like there's a lot of families that live between the two. Does Las Cruces have its own information exchange? No, I think I know the answer with that phase. So probably not yet, and I'm going to use the word yet. Would that be something are we working with anyone in Las Cruces? I know it's a different state. There are different policies, procedures in place. I respect all that.
We do have partners in Las Cruces. We don't have any of the major hospital systems, but we do have partners, some rehab hospitals, some outpatient clinics and specialists there. And then we work with a hospital in Silver City, New Mexico, Gila Regional Medical Center as well. So we're working on growing in southern New Mexico, and it's all one big healthcare community across 2 states. So that's our goal.
And I'm just going to ask this question, and I don't even know if there's an answer for it. So again, with people going back and forth with Las Cruces, we also have a very large population that goes back and forth between Mexico. Is that even anything that is on the foresight, Because I know the Paso Norte, I know that everybody works with everyone else. There's always the desire. I know you work a lot with Juarez. What is the situation there, if any?
We have it in our strategic plan over the next 3 years to explore what that could look like. There's a lot of complications from an aligning legal from both sides of the border, aligning how everything works from a consent perspective for patients to allow the data to go across the international border. But it is on our radar because we know it's an important aspect of health in our communities that patients do cross the border. From a public health perspective, I know that's a desire as well. Dr. Ocaranza.
Definitely,
Feel free to chime in on that, yeah.
Definitely, and we continue to reach out and be partners, hence the name Paso del Norte, in health information exchange, in which we hopefully one day can have that bidirectional communication with our partners from Mexico and Juarez, because many people come from Juarez to receive medical care here, and vice versa. A lot of the people go back and forth. So having a way to look at medications, to look at procedures, is going to make things a lot easier for those healthcare providers that are rendering the service to that individual patient, without having to duplicate many of the studies, many of the medications, which can pose a risk to each patient. So, and in the public health perspective, we know that diseases know no borders. So those political borders, either between states or between countries, we need to see what is happening and what is affecting to the whole community, the whole region. And we're breaking ground, as Dr. Hendryx said. We've done so much more than the rest of the state of Texas or New Mexico, and we will continue doing that. We want to continue putting those building blocks.
And tell me, why and how is it? I feel like when we talked about this with vaccination several years back, El Paso was boom, front and center. We were ahead. We are ahead with this too. Why is that? Why is El Paso such a special community that likes to work with each other? I say that because we are also, this program is aired in other states around the country on different PBS stations. And so this is a way to brag about ourselves.
I want to very confidently say that it's because of the special people that we have.
I agree.
And Dr. Henry and Emily are very, very good special people that we have, and many others that are leading these efforts. So I think in that regards, kudos to the whole community, because we have the will, and we want to continue doing something good.
I love hearing that. Dr. Hendryx?
Yeah, I think kind of adding on to what Dr. Ocaranza said is that the relationship between physicians and their patients is very good. And they listen to their patients and not Dr. Gruel. I mean, the patients listen to the doctor. And so I think that helps. If you have a belief in what they're saying, if you trust what they're saying because they've been with you for a long time,
right?
Then I think that helps. It's not universal, but it certainly does help as we move forward.
I agree completely. There are, and I just have this here actually from questions. I still have all my questions from the last time we did a program about 5 years ago. And at that time, one of the questions was, are there any patients who are concerned about privacy? And this may be another thing. We all hear about HIPAA. I don't know what the acronym HIPAA stands for anymore. I used to. I remember what it stood for in the past. But there's HIPAA. If we know the acronym, great, let it throw out there. But is there any? Is there
Information Portable Act?
Say it again.
Health Information Portable Act.
Portable Act. Okay.
You can't give out information without the consent of the patient.
Okay. So anyone that has any concerns about their information out there, is that even a concern anymore at all?
Yes.
Okay.
So whenever you go to the hospital, you can opt out of sending information to FIX.
Okay.
There is a box. You can check it. You just don't have to send it. When you go to your doctor, if they're a member of FIX, they don't have to. If you say no, you don't have to send it.
Okay. And percentage-wise, do you think there's a lot of people that do that? I would think it's so super informative and good to have all the medical systems that you're dealing with have your health information. And again, if you're in a car accident, if you have emergency surgery for something, they can look you up and boom, she's allergic to these drugs. It's such a beautiful thing. And that would beg the question of who would not want to have that. Do you find that that's really an issue here?
It's not common. It's less than 1% of the patients. We have a less than 1% opt-out rate, but we certainly respect it when patients do want to opt out. That's obviously their choice, and we help them through that process, or their providers help them through that process if that's their preference. But you're absolutely right. I mean, being part of FIX, we've seen it save lives. We've seen the impact of when FIX is accessed after a hospital visit by a primary care physician. We published a study in 2023 that showed that after that hospital visit, when FIX is accessed by primary care, there is a 61% decrease in rehospitalization for those patients, and a 53% decrease in return to the emergency department. So there's a huge impact on having your information shared across your network of providers, but not everybody wants that, and certainly we respect that as well with the opt-out process.
So for the information of everybody that's listening and watching right now, so 61% decrease of actually returning. Explain, I mean, I think we here at the table understand why, but explain to the audience who's not familiar with this.
Yeah.
Why is that?
It's because your physician is able to see exactly what happened to you in the hospital in detail. All of the labs that you had were there, all of the notes that were written, any radiology studies that were done, they're all there at their fingertips. And so they're able to see exactly what they need in order to best direct your care, do a medication reconciliation, send you for follow-up studies, make sure that they have all the information they need to do that most effectively.
So you are helping me here with further questions when you're doing a medication reconciliation. And this is, again, in the old days when we used to joke. It's like, okay, Mom, put all of your medications in a plastic bag and bring them with us. Now that is all in one place. And here's the question, too. There are times when it's, okay, it's time to go off this medication and start that medication. And is that something that FIX, again, you were talking, Dr. Hendryx, that the healthcare system is what puts that information in. So is that always kept up to date? How does that usually work? Again, when I check in, what medications are you still taking? And sometimes I'm like, I remember what that one was for, and then I'll just kind of skip it. Is that re-looked at every time there's a medical appointment, or how is that usually done? Dr. Hendryx?
Well, from the hospital side, we have to do a medical reconciliation every time you come in, you're admitted to the hospital. When you're admitted, we are mandated to do a medical reconciliation. So we take, if you're in the system, then that really helps. And if there's some question about if we can get information from FIX, then that's even better, right? Mm-hmm. Whenever you're discharged, there has to be a medicine reconciliation of your discharge medications. That is, once again, posted to FIX. As a provider, if I'm a part of FIX, then I can go to that FIX and I can say, okay, well, these are the medications they were discharged with. Are they going to interact with what I want to do? Do I want to change them? Do I want to say, yeah, no, that's a great thing? Or, you know what, we need to get you a consult with somebody else because this is a medication that determined you need a consult for heart or for kidneys or whatever it is. So medical reconciliation is a big factor within the hospital system. Mm-hmm. Now, if I'm a private doctor and I don't necessarily do a medical reconciliation and upload it to FIX. I should. Sometimes, most of the time they do, but it may not be 100%.
Okay.
But when they do go to a hospital system, it doesn't matter whether it's a Tenet hospital, HCA hospital, UMC, any of those hospitals have to do a med reconciliation.
So you hit on a great point. That was my next questions. Will private practice physicians be part of FIX? Again, this is from years ago. So we were talking about hospital systems. We were talking about a mandate with mm-hmm. Medicaid and Medicare. What are the rules, if any? And again, we're in El Paso, so everybody wants to help each other out, which is awesome. But with private physicians and whoever would like to take that. Are there any mandates there or any rules to follow?
No.
Okay.
So El Paso County Medical Society, working with FIX, for their members, we came up with a special deal with them to be able to have them join FIX. And Emily was very good about working with the physicians, training their staff on how that works. And it is a value. So if I'm a physician, I've got all these extra, if it's an extra fee and if it's minimal, but I get a lot of value from it, then that's good. So, but not everybody sees it as a value. And so, therefore, what we want to do is try to introduce to them this idea that it is a big value and that value is to your patient.
Absolutely.
And so, if you're able to have the information, that communication, and you're able to sit there in your mind, come up with a plan for your patient with that information, that's a value.
Right.
But how you translate that into everybody seeing it that way is a little more of a challenge because they've not done it. And once they get to do
It's something new.
Once they get to do it, then, we've had good success. And I think Emily can talk to some of the success stories she's had with private groups, small groups, private doctors, community clinics.
Let's talk about that. Let's take that, because we've kind of covered all the big stuff here. So this is where I like getting into the weeds a little bit, because I think it helps people understand why it's important to share that information and what it is that, aside from this, like what you and your staff are doing to bring on as many participants as possible.
Yeah, absolutely. So right now we have about 350 and growing number of outpatient clinics that are part of our system. And we love our partnership with the El Paso County Medical Society because it allows us to reach out to folks who may be interested in the system and talk about value. I think, of course, there's no mandate, so it's about us explaining the value and talking to them, not just us talking to them, but telling the stories of their peers and how they use it to create efficiencies within their clinic and how they use it to benefit patient care as well. And always taking their feedback. I don't know if you want to add to that.
Sure, and I'll put it in perspective. If we see it in the patient's eyes, if I'm a patient, I go to the physician's office and I'm going to be waiting, and you brought that point that before we used to sign papers, the release of information, let me fax it to the other physician, let me fax it to the hospital, and we go to the patient like, do you remember where you got those studies done? Do you remember where you got that procedure done? No, I believe it's here, maybe it's there.
Right.
So in the meantime, you're still waiting, and we as physicians, we want to have the results so we can start putting everything together so we can develop a plan for you and not duplicate the services. And we're not going to be prescribing a medication that you're already taking, or you take something that is very similar and now you're doubling on the medication. So all that is the value that fix is bringing, because now that I have your name, your authorization to access the records, it's going to be populating into your health record, and that's how we build that record in a more comprehensive way so we can deliver better care for you. So does it bring value? Of course it brings a lot of value, because I don't have to be having 2-3 girls calling each hospital to fax me that information. Now I can have it in the electronic health record, and now as a physician, I'm not going to be spending that much time waiting for those, but I'm going to be spending time looking at you,
Right.
checking you, providing that care that you need.
That true one-on-one time.
Exactly. And that's what we all want. We all want that one-on-one time with you. So,
And I don't know, and this is a question that in my head I'm thinking, and I keep hearing the word mandate. So far it's not a mandate for all physicians. Do any of the three of you on this table foresee that being a mandate in the future for anyone who is truly practicing medicine, healthcare? And I go, clinics, sometimes it's not necessarily a doctor, but may be a physician's assistant. Is that something that you see? Is it?
So I think, if you look at it from a political structure, so El Paso is so far advanced over most. I've had the fortunate opportunity to deal with a lot of the big Texas teaching hospitals, and we were so far ahead of them in many ways.
I love that you're saying that. Yes.
And with that, saying that there's a state mandate trying to create an umbrella thing so that everybody can exchange everything, but it's not near as good as what it is my opinion, and that's only my opinion.
It is your fact that you're stating that El Paso rocks that way.
Yeah, we have a better system, and we want to make sure that we're not smothered by that system, hopefully, that we're able to show the value that we do and be a leader in how you exchange information. Because I think everybody wants the same thing. That's why we had electronic medical records. Why? Because we were wanting to share that information, but the mandate will, if it comes, will come through potentially political.
Yeah.
And that, we don't know. We have no idea in the future what that is. Emily is given, she has testified, and she's been giving lectures and everything to the state and even nationally on our system. And she's done a great job.
So that's a great point there. So the reception of you coming to meet with different legislators, what if any are arguments? Is it, I always feel like everything comes down to money. You know, it's funding, the funding this and the funding that. And I don't know if that's the case. But what are you being met with when you go and have these meetings?
I think for us, because we're fortunate that our partners fund our organization, our funding comes from our members, and so we're not going necessarily for a funding ask to the legislature. It's more educating them on the work that we do and trying to make sure that we're represented in conversations about data sharing at the state level, and that we can contribute as appropriate, you know, to those conversations and to being a pilot site, really like an innovator in the state that others can look to for what they might be able to do in their communities, because we really are doing some great work with our partners here, and we just want to make sure folks recognize that, and that, to Dr. Hendryx's point, we get to continue to do the great work that we're doing here locally.
So when you're looking at different systems in Texas, trying to get them up to speed like El Paso is, how is that working now, and how do you see that working in the next 5 years?
It's not the same depth of information that we have and we're able to exchange within our local network of partners, but it's at least some information so that they can even know who his providers are in El Paso. To your point, Dr. Ocaranza, even knowing who to call and high-level diagnoses and medical history gets you a long way to knowing how to approach care for somebody when they're in a different community.
Right. Is there a certain state that is kind of on the forefront, like El Paso is now as a city, but is there certain areas of the country that see this more as an importance than others?
It varies. Every state and every regional model of health information exchange nationally has a different focus. We're really heavy into use cases with our public health department and with our providers and working on analytics. There's others that do and emphasize different types of work, maybe working with non-medical drivers of health. San Diego is really good at that. They were at the forefront of looking at folks across different sectors, looking at emergency department utilization among those who are receiving housing services and are justice involved, just as an example, and using that information to drive kind of community thought leadership around where should we really be investing dollars in our community to truly benefit and wrap around services for these folks. So we try to look to those examples nationally, but we also have folks that are looking to us, and we talk with folks from New York. Actually, we have a regular call with them to collaborate on the analytics work that we're doing and share the work we're doing to help advance what they're working on. So it's...
And I'm a cheater because Dr. Hendryx wrote something down in his paper, and I can see it from here, and he wrote down the word research. So why did you write that down? And I'm thinking this is somehow affiliated with everything that we're looking at here. And I'd like to know, too, with this information exchange, with these studies, you guys were talking about the grants, too, that the city has given to you. But in the area of research, what do you see going forward with that?
Well, certainly Emily talked about de-identified data. And when you're
de-identified data.
So whenever there's no names attached to any data, you're able to aggregate that data and analyze that data. Dr. Ocaranza has done an excellent job within our county of looking at that. Started certainly from a research point of view, whether it's a private research, whether it's, say, for example, Texas Tech. They have a lot of research, and there was a study on COVID and certain medications. Is that effective for treating COVID as far as readmissions, as far as comorbidities, et cetera? So that is one of the really interesting aspects of all this data, because you're able to utilize that in such an interesting way There was a doctor from Washington? No.
Brigham Young.
Brigham Young, who, I don't think Fix gives out data just to anybody. It goes through the board, it has to be approved, it has to be specific for that. It's not commercial, it is specifically for a research project. And with that, you're able to look at some data. I think they're looking at from the University of Houston of looking at things. They're doing stuff, we're doing things. Can you compare the data? Can you say, this data is comparable? These are the things that we're seeing. What are you seeing? Research is important. And, it doesn't necessarily treat your diabetes, but it may give you an idea of where you're going to go to treat that diabetes. And, once again, it's validating your assumptions or not. Maybe we are wrong in our assumptions.
You brought up a point too, and Dr. Ocaranza, I'm going to ask you about this. So you said there was a lot of information being put in during the time of COVID because there are just people that were going to see the doctors that may not have seen them in years. I remember when we were doing some of our programs during the time of COVID, we said to ourselves, 10 years from now, it'd be very, very interesting what the data that has been gathered over this last decade will show us about, yes, what happened and what was going on during COVID, but then there's that big question of long COVID. I think is it still called long COVID? And the data that is being gathered there. So I'd love for you to just maybe take that tangent a little bit with a lot of information that was gathered during COVID. If there's long COVID, now we're looking at 4 or 5 years out. Where are we going to be 5 years from then with people that did have COVID, et cetera? Only because I want to say 3 years ago, we talked specifically about this during one of the programs, and here we're 3 years out, and we know a lot more now, right?
Exactly, and if we talk about COVID, there was many factors that we didn't know.
Right.
And looking at the data, now we know who can get long COVID. What were the effects of the vaccination? What are the effects of COVID initially compared to now? But there's a lot of data that we collect that we're like, okay, what happens if we put this and we analyze the effects of X into the health of Y? And that's what Emily and the group did with environmental factors and heart attacks. So, and there's a lot of success stories in public health when we look at data, meaning vaccination, meaning the use of seatbelts. We used to be jumping in the backseat with no
right. How are we still
seatbelts?
I'm with you.
And we're still alive, but many of them are not. And that data, it definitely gave us that chance to go to the legislators and promote some new laws. And that's what also has been helpful, in which we're creating laws to make things safer. Is it because of the pollution that the cars are giving us? And that's what we're
right.
Now,
and Emily just talked about that with pollution. Yeah, exactly.
Yeah. Now the cars need to have specific anti-pollutants. So things like that are extremely important, and that's how we want to collect data. We want to do that research. We want to apply it into making things better.
And here's another point of that study too, which I think is interesting, the relationship between income and health, so underserved communities and health. And Emily, I'm going to pass this your way too to show people what we have on this map, and Diego, I'll tell you what. Diego's the guy that does all the magic and puts all the charts in, so I'm letting him know what charts we're using. But on this chart here, when you're looking at our community and the different areas of what the income is and compared to health, explain why that's important and why it's good for the health community and providers to understand that.
Sure, so this particular example is looking at type 2 diabetes prevalence across the community and overlaying it with the income level of certain census tracts, which are really small geographic areas, to understand the relationship between type 2 diabetes and income. And so you can see that there's areas with both low income and high prevalence of type 2 diabetes. And that's a challenge for our healthcare community because type 2 diabetes is related to lifestyle and impacted by things like healthy eating and exercising. And that's all far more difficult to do
if you have a low income. And so it's providing that information back to our healthcare community to inform different strategies and programs that may be able to benefit those communities in a unique way, given both the prevalence of the disease, but also the income of the community.
And there's one here too, which I think is super important, is senior falls. You know, people who are elderly, and where they may... We were talking about the Blues Clues couch earlier. We were all sitting in that couch like, man, it's hard to get out of this couch. But when I was 12, it wasn't that hard. But in general, we do have areas of the population that are more aged than other areas of the city. So talk a little bit about that too, and how that is helpful for the knowledge.
Sure, absolutely. So this is looking at, again, at vulnerable groups. So seniors who are falling, what is their impact in terms of other conditions that they may have that may be contributing to the risk to fall, how many falls you're seeing per senior, because once you fall once, there's a higher likelihood that you'll have a subsequent fall that could lead to a longer length of stay in the hospital and worse health outcomes. And so what this is also showing is an increase in senior falls over time, and so it's an important public health issue for our community.
Very nice. And so, Dr. Ocaranza, I feel like you, the public health authority, or just the health authority, excuse me. Yes, sir, just the health authority.
That's it.
And a pediatrician, which is great, right? You want to ask every pediatrician about the future. And that is my next question. So, in the area of data exchange, and again, I foresee, hopefully, that the nation will be on this system pretty soon, and there's more and more talking. But what do you see, and Dr. Hendryx, I'm going to ask you the same question in a moment too, what do you see in the future with everything that we're speaking about today?
Well, I see that we will be able to predict a little bit better, although that's one of the new frontiers that we're trying to explore. How can we predict what's happening? Weather ladies are great at predicting what's going to happen, even the weather a week from now. But unfortunately, we don't know what's going to happen with influenza in a month. But we're getting close to know, okay, where are the trends taking us within a week? Are we going to see a spike? Are we going to see a decrease? And that's why historical data help us make that assumption, so we can very safely say, well, we're going to be within these parameters, and therefore we might expect to see something happening with a specific virus. We're doing this with infectious diseases a little bit more, and with infectious diseases that we have some history, that are giving us that comfort zone to be able to say what might happen. So we see that in public health, which help us say, okay, in El Paso, now historically all these years, we see that the flu season runs from October to April. And we see that the peak is going to be between the middle of December till the end of January. Everybody get ready. Let's start doing activities before that happens, so we can see if we can modify that disease in such a way that we don't see those peaks that everybody was seeing, or even worse, to see a pandemic that is going to be killing people,
right,
making them more vulnerable, and that's our job.
So we were, I always think too, one of my favorite shows is when you're looking at ancestral type information. I'm thinking too, with this, if cancer sees to be what we talk about a lot when you're doing gene testing.
Just don't invite us to that program. We're not that ancestors yet.
Not yet. I'm happy to be an ancestor anytime. But when we're looking at BRCA genes, for example, and you've got a grandmother and a mother and a granddaughter, and I'm thinking too that maybe in the future this could be very helpful when you're looking at lineage and trying to tie people together. I could be wrong, but it's just something that I think about often when they're doing that now. And is that in these systems, again, El Paso, but if I've got grandma in Montana and an aunt in Hawaii, not yet. But do you see that? So when you say we're doing that now, explain what's current and what you see going forward.
So if I'm taking care of a patient and I notice that, there's a cancer history, and once again, it has to be a good history. And it can either come from fix, it can come from just talking to the patient. So once you know that, then a light goes off, right? So, okay, well, there's breast cancer, there's ovarian cancer, there's something going on here. And then that may trigger going testing for it. So, and you have to ask the patient because some people don't want to know.
Yeah.
And having said that, so in a sense, it's already within the medical community. It's not, to her point, it's not patient-facing. In other words, a patient can't go and say, okay, I've got that. This is a communication between you and the physician. You know, you bring your concerns, whether you've researched it or, you know, you've talked to your relative, and that is that conversation that you get to have with your doctor on what you need to do to protect yourself, to be knowledgeable about it or not, because that is a choice that individuals get to make.
And I do respect that. Some people don't want to know. I'd want to know, but I get that.
That is a choice.
And I'm just thinking, you know, the 23andMe tests out there, and it can get so convoluted, and I think that's a topic for another day on another program. So I want to thank you all so much for being here. Is there anything else that we want to talk about before we get off the air? Dr. Hendryx?
Yeah, I want to say that, you know, certainly being a part of the proud El Paso community, I've really touted, you know, Fix and all the different things that they're doing. I want to emphasize that other people are doing great things too within the state of Texas. They may be doing it a little bit different, and, you know, and they're trying their best to get that information, to be able to share that information, because they want the best for their patients too. They may go about it a little differently, but they are trying that here, not only in Texas, but across the nation. You know, once again, I'm so proud of what Emily and her group.
I love everything about that. Yes.
I just can't say enough about it. But I don't want to. There are other people doing a lot of great work.
That was me. You did say that, but I'm like, you know, sometimes I just love getting proud about what we do.
And the other part of it is, you know, certainly we always talk about AI. And that is going to be a factor as we move forward, because that's going to be a part of that information exchange. We don't know where that's going at this point. And it will flesh itself out as we go further.
Right.
But I think that's going to be a big part of some of these graphs, of being able to analyze those graphs. And how is that going to leverage the information, the exchange of that we are able to help us guide the care and the emphasis on that care.
Agreed. And again, leveraging. It's all about the leveraging. Thank you so much. That's Dr. Joel Hendryx, who again is Chief Medical Officer over at the University Medical Center. Also on the Fix board, we have Dr. Hector Ocaranza, who is the Health Authority. Also on the Fix board, and Emily Hartmann, who is the Executive Director of Fix. And again, Fix stands for Paso del Norte Health Information Exchange. But thank you so much for watching. This is the El Paso Physician. I'm Catherine Berg, and good evening.